Hello, welcome to our multimodality imaging conference. Thank you for joining us today. I'm Valeria Duarte. I'm one of the adult congenital cardiologists and cardiac imagers here at the Houston Methodist, and I'm delighted to present our first congenital heart disease imaging lecture for this year. As you know, it's very hard, challenging to discuss all the congenital heart defects in a couple of lectures, but we'll do our best to give you a flavor and more importantly show you a general approach to congenital imaging. So I always start my congenital talks with slides that look like this or look similar to these. I just want to highlight that the ACHD population is growing. As you can see here, this is from 2016, 1.5 million adults living with congenital heart disease in the United States. And if you pay attention a little higher, you can see that there is less than 1 million children. So right now, there are more adults living with congenital heart disease than children. So this is, some people call this the sleeping giant. Because more and more there has been a dramatic change in the prognosis of these patients as a result of the evolution of congenital heart surgery and congenital cardiac care overall. The same pattern applies in other countries. This is from the European Union, sorry, and you can see here this starts in the 2000s, and you can see the prevalence here is growing. This was published in 2014, so right now we're more here. And you can see that the children with congenital heart disease is an overall stable population, and the ACHD population keeps growing. And you can see that not only those who are less than 60 years old, but also patients with congenital ACHD that are over 60 years old is also a growing population. So if you are not seeing congenital heart disease in your imaging labs, you are missing it. So a good resource to handle this, to manage these patients, and good guidance is provided by the 2018 AHA-ACC ACHD guidelines. So this is a good framework, and it's also very good for the fellows to study for the boards. I think they're very to the point with very clear literature-driven data. So a few key principles to obtain an adequate study in patients with congenital heart disease: know the native anatomy and review the surgical history, review the clinic notes, the operative reports. If you practice at a center that has an ACHD program, the op notes are likely either in the notes or scanned in the chart. So look for them, because they're key as you're working through your protocol and your imaging acquisition. Then we need to focus and know and understand the different surgical approaches and long-term complications of each condition. So the same condition, for example, D-loop transposition of the great arteries, has different surgical strategies, right? Atrial switch, sending mastard, arterial switch, and some patients also are eligible for Rastelli. So and all those surgeries have different long-term complications. So it's not straightforward sometimes. And then congenital heart disease requires a multimodality approach, always. So you need to keep in mind the strength of each modality, and all of them are complementary. So when we are in the MRI lab, I always tell the fellows that this is not discovery MRI. We should look at the CT, at the echo. The more we know, the better our study is going to be. And then when you're reporting, it's important to use a language that provides that providers from different backgrounds, pediatric and adult cardiology, can understand well, right? So sometimes you need to say things in different ways. Remember that some of your referring providers will rely heavily on what you write in your reports. And they may not have access to the images if they're coming from outside institutions, so just be as detailed as you can. When the patient, this is a surgical evaluation or transplant evaluation, make sure you highlight the findings that are pertinent to surgical planning. So we are not going to review all of the congenital heart defects, but we're quickly going to review some simple and moderate conditions. We have another talk in next month, and we'll review some more complex ones then. So the guidelines classify congenital heart disease anatomy in simple. You usually have here the small shunt lesions, ASDs, VSDs, and repaired larger shunt lesions. And then in the moderate complexity, where this is going to be the thick of our lecture today, you'll find a myriad of conditions. So we'll touch on anomalous pulmonary vein returns, AV canal defects, including primum ASDs, congenital anomalies of the aortic valve, coarctation, Ebstein, primum ASDs. In the same group, we can find the pulmonary valve stenosis. We won't discuss that particularly today. Sinus Venosus defect, we'll touch on that. Subaortic AS, and repair tetralogy fellow is here too in the moderate category. So let's get started. So this is a 46-year-old with a dilated Rudon echo, and this prompted to further investigation hard echo windows. So they couldn't characterize the aortic valve very well, unfortunately. But here you can see in this first image, you can tell that the aortic valve is doming, the aortic root and the ascending aorta probably are dilated, and then you quickly confirm that this is a bicuspid aortic valve. So whenever you see this, you need to make sure that you evaluate the entire, at least thoracic aorta, and this is like a candy cane view, and you can see this patient has this not infrequent combination of bicuspid aortic valve, aortopathy, right, and also coarctation. MRI is great. MRA is great to image coarctation patients. Also CT, it's very good to image patients with coarctation, aortopathies. You can see here in this patient, this is a patient with this critical coarctation in her 30s who was diagnosed in the setting of a stroke. She had been dealing with a refractory hypertension since her 20s on multiple agents, but had not been evaluated for coarctation. And it's important that when you evaluate them with echo, you need to make sure that your echo is diagnostic, that you had a good view of the aorta and the aortic isthmus. If not, you need congenital imaging if you're trying to rule out coarctation. A cross-sectional imaging, I mean. You can see here the collaterals. You can see the collaterals near the vertebral bodies. And if you give me 1 second, I just realized that you're not seeing my pointer. So let me fix that real quick. So I'm just going to because I would really like to. So I just need to get out of presenter view. Could you help me? So you can see here prominent collaterals, right? In the intercostals, like you learn in medical school, you can see some here. And then 3D imaging is very helpful when we're assessing this. This is 3D reconstruction. You can see these collaterals coming from the limas, and those sometimes explain that you don't have a significant gradient of blood pressure when you compare the upper and lower limbs. It's very important. These patients can be repaired surgically or with transcatheter. This one in particular got a stent. You can see a very good result here. When you're evaluating bicuspid aortic valves, just make sure you look, especially when in MRI, that you look at all the frames and all the slices. In that sometimes you need high res when you're confused, because you don't want to miss a monocuspid aortic valve like this patient had here. You see, just it's a monocusp, one commissure here. And this patient was in his 20s. You can see also the jet. This should prompt you to think about something different from your usual bicuspid. You see the regurgitant jet is not your typical one, and also if you compare this to our bicuspid valve doming, this is different too. So this patient was in his 20s, referred to us for transplant evaluation due to biventricular severe enlargement and severe biventricular failure. As you can see here, he ended up going with a high-risk aortic valve replacement, mechanical, as you can see here, and the remodeling was, he had significant reverse remodeling on follow-up MRI. So a good result, AR, when you take care of it on time, the reverse remodeling is impressive. No. So moving on to Ebstein anomaly of the tricuspid valve. So I get many calls regarding suspicion for Ebstein anomaly, and I always tell the fellows that if you're doubting it, if you're having a hard time to make the diagnosis, it's probably not Ebstein. If you're measuring the millimeters and trying to figure out the displacement, if it meets the cutoff or not, that's probably not Ebstein, because Ebstein is, the displacement is just a part of it. Ebstein it's due to failure of the delamination of the tricuspid valve leaflets, and that results on apical displacement of the tricuspid valve. As you can see here, the coaptation is very close to the apex, and that leads to severe tricuspid regurgitation and atrialization of the right ventricle, right? You can see this portion here is atrialized right ventricle. And just with color, I'm going to show you. Sometimes it may be tricky to assess the severity of tricuspid regurgitation in Ebstein anomaly, just because the valves sometimes are so displaced and rotated that the direction of the jet may be towards the RVOT, so your usual 4-chamber view may not be enough. Remember that you need to image the RV so you can see it in full extent. You can see here that this is the patient with severe TR and Ebstein anomaly. We love 3D echocardiography in congenital heart disease. This is the same patient, and you can see the tricuspid valve on fast, and you can clearly see the lack of coaptation here. So I'm going to quickly show you a patient with a subaortic membrane. In the parasternal log axis, you can already see the membrane here, right? And if you pay attention, you can see that looks like there is a membrane attached to the mitral valve leaflet here. So that will make you suspect that the membrane is not as discrete. Here with color, we can see flow acceleration at that level, and then again using 3D transthoracic echocardiography. This is a great picture. You see, we're looking right at where I show you that membrane, and you can see this circumferential subaortic membrane right below the aortic valve. Can you all see it clearly? Yeah. So right here, circumferential. This patient already very young too, with LVH, and that underwent intervention. The anomalous pulmonary vein return are the most frequently missed congenital anomalies, And we're not going to review all those cases, we just don't have time, but I wanted to show you a Scimitar syndrome, that is a more extreme case, but they really like it in the boards, in the imaging boards. I'm frequently told that it's tested. So Scimitar syndrome is anomalous pulmonary vein return. Usually all the right-sided pulmonary veins drained into a vertical vein that drains into the IVC. You can see this is one of our patients here that is now repaired, and you can see the Scimitar vein draining into the IVC. So the way you fix this is by baffling, meaning redirecting the flow that comes from this vein through the atrial septum. So it requires the creation of an atrial septal defect and then baffling with usually pericardium. This should be done by an experienced congenital surgeon to prevent stenosis of the IVC or obstruction. So this is a 49-year-old with palpitations. As you can quickly see, there is here a secundum atrial defect. Secundum ASDs lead to right ventricular volume overload and dilation, and sometimes dilated tricuspid annulus and functional TR. So when we image these patients, our referring cardiologists are usually very interested in knowing the rims because that's what's going to help them decide which patients are candidates for percutaneous intervention. And so the most important ones to report are the posterior rim. That is, as you can see, the largest one and represents a major anchor for the septal occluders, the transcatheter septal occluders. There is a lot of interest in the aortic rim, and you need to report it because different interventionalists may decide on different devices depending on the presence or absence of the aortic rim. But a deficient aortic rim does not preclude percutaneous closure. As you can see, compared to the posterior rim, this is a very small one. It's not infrequent to have a deficient aortic rim, but just report it because it's of interest in device choice, I should say. An appropriate rim is a rim that is at least 5 millimeters, okay? So don't forget to report that. The defect size is also important. Some defects are too big for a transcatheter closure device, and then for indication of closure, just remember QPQS to make sure that this is hemodynamically significant or not. So that's a QPQS of over 1.5, and then the RV and RA size and function are critical. So when we try to determine what's the difference between a secundum ASD and a primum ASD, so this is a diagram that just to help on that. The secundum ASD is located in the fossa ovalis usually, and the primum ASD is located closer, more apically, if you will, closer to at the cracks of the heart and very close to the AV valves, to the mitral valve and the tricuspid valve, and that's why ostium primum usually are associated with anomalies of the mitral valve. Okay, so here in this graph, you can see this is where you may find the secundum ASDs, and then this is where you will find the primum, closer to the cracks of the heart, okay? So you just need to look at this piece of septum that is between the AV valve and the fossa ovalis. So let's move to an example here. This is a 29-year-old with atrial flutter. Patients with shunt lesions frequently present with arrhythmias, as you can gather from here. And you can see that looking at the septum, the fossa ovalis looked intact. And you can see that you're missing the septum near the cracks of the heart here. So this is a patient with a primum ASD who also has a mitral regurgitation that looks eccentric if you pay attention. and that's, in this case, due to a frequently associated lesion that is a cleft mitral valve. You can see here how this anterior leaflet has a cleft here that usually is addressed by the surgeon at the time of closure of the primum ASD by suturing, not all the way to avoid stenosis. And if you like color, this is what it looks like. So let's continue with our list of moderate complexity defects. Can somebody tell me how am I doing with time? Please, I just left my phone behind. 12:20. Oh, okay. I can slow down. Okay. All right. So let's look at this patient. This is a 48-year-old with a dilated RV on echo. However, no defects were visualized. So this is an axial stack, sinus stack. I love this, especially when I'm looking for defects that are undiagnosed. And as you can see here, we're going from superior to inferior. And I played it once and we'll play it again. You can see we're looking again at the coronary, the IVC looks intact here. Again, superior, anterior, posterior, vertebral bodies here, your lungs here, aortic arch, innominate. Here, this is the SVC. We see the acicals coming in. We follow it down. And then we can see here, and I'll just slow down for clarity. We can see here that as the pulmonary vein courses towards the left atrium, there is an area of overlap between the posterior wall of the superior vena cava and the anterior wall, if you will, of the right upper pulmonary vein, and that area is here missing. So I'll play it again for everybody to get a chance to look at this. So this is the way I like to screen for this, looking at my axial stacks, identifying the innominate, identifying the superior vena cava, and you can see the defect there, right there. And you see that if you didn't image all the way up, you would have missed it. The atrial septum per se looks intact. And so this is a sinus venosus defect, right? It's harder to diagnose it by echo, very much possible with a skilled sonographer and trained in ACHD. It does take out of the ordinary views. And you can see the defect is right there as the pulmonary vein is courses here. So that's what you measure when you report. In the sinus venosus defect, there are two. Always assess the pulmonary venous anatomy. As you could see here, and I always say this, in the sinus venosus defect, this is not truly or anatomically an atrial septal defect. The atrial septum is intact in these patients. The defect is between the SVC and the right upper pulmonary vein. And so anomalous pulmonary vein return is part of the definition of this defect, not an associated anomaly, truly. Without that, there is no diagnosis. And you will need to look, obviously, always, as we do with all the shunts above the tricuspid valve, to the RV size and function. Usually, by the time of diagnosis, they need surgical intervention. These defects are always surgical. In other countries, they do have transcatheter approaches, and I think we're going to learn a lot from their experience, and mostly overseas. And we're going to learn from that, and I think there might be a role in the future for transcatheter options for these defects. But right now in the US, they are always surgical. The surgical interventions for sinus venosus defect include the double patch technique, where you place a patch right there where I show you that you measure the defect, and also you augment the SVC to prevent SVC stenosis. So that's where the second patch goes. The Warden operation is another surgery for sinus venosus defect, and there are some centers in which this is the preferred operation. So you will see both. And I'll quickly show you this. The Warden operation involves division of the SVC, right? So this was the SVC coming here, and it got divided. Okay, that's the first step. The second step is baffling the pulmonary vein or veins that were coming to the SVC, to the LA. And then the divided SVC gets anastomosed to the right atrial appendage. So that's the third step here. So I know that frequently I'm asked, yes?
Is there a preferred reason to use one approach versus the other?
Yes, it usually is where the anomalous pulmonary veins are draining. Sometimes a Warden is hard to do if you have another anomalous pulmonary vein coming very high, because then it's hard to divide and stretch it all the way to the right atrial appendage. But yeah, that's the one criteria for those surgeons that do both. But there are in general, there are surgeons that prefer one versus the other. Yes, so different.
Not based on long-term patency or anything, just kind of surgical preference.
Surgical preference. That's right. That's right. And then I am frequently asked if these patients need to be imaged after repair, and how often, and what do we look for. So in congenital heart disease, the answer is always yes. Patients with ACHD need care for life, and that means establishing care with an ACHD cardiologist, and also routine imaging for long-term complications of their surgeries or progression of their disease. And so just as an example, this is the same patient, the patient that had the Warden, that presented with elevated JV pressures this is another patient, so sorry, younger, that had elevated JV pressures after a Warden, and he didn't look like he was in heart failure. The right ventricle had significantly reverse remodeled. So in imaging, you can see this is an MRI. This is close to a bicable view in a post-surgical anatomy. This is the SVC, and this is the anastomosis site. This was the right atrial appendage, and you can see flow acceleration here. And this is not frequently seen because, as you know, the right atrial appendage has pectinate muscles, and it is not as straightforward to remove those at the time of surgery. So that was the reason why he had the elevated JVP, and he fortunately had an azygos vein that wasn't ligated during surgery, so the SVC was decompressing towards the IVC through the azygos vein. That's another thing, and that's why it's important to have the op notes. Sometimes the azygos will get ligated during the surgical, just in an effort to mobilize the SVC. Some surgeons will do that. So this is another patient, a 54-year-old with atrial arrhythmias again, and decreased exercise capacity, very active sportsman, and so noted that couldn't keep up with his usual activities. And let me just give you some more history before we play this. So this patient had an ASD repair in the 70s, and on echo was found to have severe RA and RV enlargement. And very interestingly, his O2 saturations dropped with exercise from the 90s to high 70s. So when you have an ASD repair, the first thing that everybody wants to make sure is that he didn't have a residual ASD, and especially with the surgery back in the 70s. And you can see here the atrial septum. We look at it from superior to inferior, and it appears to be intact, right? And so as we follow, we can also notice the RV, the RA, dilated, significant tricuspid regurgitation. So when that happens, you really need to investigate, and we do this routinely in our congenital scans. You need to further look harder for the shunt. So to examine the atrial septum, we do oblique cuts across the septum, and I'll show you the result of this. And you can see here, this is the right atrium, the left atrium, the atrial septum, the liver here, the IVC coming in. And as you can see, if you follow this, there is here an inferior sinus venosus defect right there. That was probably not seen at the time of surgery back in the 70s. Right now, at least at this institution, every patient with congenital heart disease that is going to the OR undergoes cross-sectional imaging for surgical planning and to make sure that we don't have any associated defects. This is with color. You can see here the IVC flow that's going to the RA, and it's also going here to the LA. And the reason why this patient is saturated with exercise was probably when he was on the bike, he increased the venous return from the lower extremities and the flow via the IVC, and had more shunting in the setting of exercise. All right, so, and then patent ductus arteriosus, this is just a cute 3D reconstruction to show you. Also can be missed in imaging, in cross-sectional imaging that is not ordered for congenital reasons. So always be on the look. Always make sure you look for the pulmonary veins and for the ductus. Don't miss it. Sometimes we find them on echocardiography. If you follow the protocol, if you follow a congenital protocol and you systematically assess the main pulmonary artery and the branch pulmonary arteries, you won't miss it. And the same thing when you're looking at your angiograms. The one thing to clarify here, when you calculate the QPQS in a patent ductus arteriosus, is slightly different what you will usually do, and it's just because of the location of the shunt. So very simplistically, you just flip your flow. So if you're using instead of using the pulmonary artery forward flow for your QP, you will use the aortic forward flow, and in the denominator, you will use the pulmonary artery forward flow. And this is just because of where the shunt is, right? So it's not accounted for at the usual places where you measure the flow. All right, so tetralogy of Fallopian, I think this is the last one I have to discuss. So tetralogy of Fallopian is in the moderate category. Their outcomes have improved significantly. We have patients that are beyond their 60s, and also, just in clinic today, with Yahya, we saw at least 2 of them, and both of them active, and they usually, with the right care, their survival is outstanding. So tetralogy fallow, as you all know, it is caused by the anterior malalignment of the conal septum. Okay, the conal septum is the part of the septum that is simplistically between the outflows. So when it malaligns anteriorly, it causes obstruction of the RVOT, and that's the major problem in tetralogy of Fallot. It also causes a conoventricular VSD, overriding of the aorta, and the RVH is just a secondary finding to the RVOT obstruction. There are many, the 2 main steps of the surgical repair of the tetralogy flow are the closure of the VSD, as you can see here, and the relief of the RVOT obstruction. If the obstruction is only at the RVOT level, then these patients will undergo a valve sparing repair with a resection of muscle bundles in the RVOT, plus usually an RVOT patch. If the pulmonary annulus is small and there is valvular stenosis, then those patients may need a patch like the one you see here, that is a transannular patch. Patients that were operated on earlier, in an earlier surgical era, are more likely to have this approach. So when we evaluate these patients with imaging, we need to pay close attention to the pulmonary valve function. Pulmonary valve regurgitation is by far the most frequent long-term complication of the tetralogy flow, and some patients can have stenosis too. We need to look at the RV size and function, the RVOT dimensions, as we're thinking, considering therapies for the pulmonary valve, especially the LV size, because when the RV is very dilated, and you can have LV dysfunction. And also we need to pay attention to the VSD repair, even though it's not that frequent to find a residual VSD. Tetralogy, not all the tetralogy fellow patients are the same. There are patients, there is a severity spectrum, and we can have a full seminar to discuss that. But today, for the sake of time, I'm just going to limit to say that you can have patients who have RVOT obstruction and pulmonary plus minus pulmonary stenosis, and then you can have patients who have pulmonary atresia, tetralogy flow and pulmonary atresia. There is no valvular tissue, and then you can have patients with tetralogy flow and pulmonary atresia who don't have a pulmonary trunk, or who have discontinuous pulmonary arteries, or who have no recognizable pulmonary arteries even, and whose lungs are perfused by major aortopulmonary collaterals. So tetralogy flow in the adult patient, echo is it's our preferred way of assessing them in clinic, and especially when we're meeting a patient for the first time. As I said, the pulmonary valve is of great interest, and we should look for pulmonary regurgitation. Like you can see here, it's important to note that because there is equalization of pressures, the pulmonary regurgitant jet can be very short, and you can miss it. And the same goes when you're examining them in clinic. And like the fellows that work with me in clinic can tell, the murmur is very short and faint sometimes. So you have to pay attention. And in echo, you need to go sometimes frame by frame to not miss this. And also, the flow doesn't look as turbulent, and so it's frequently missed. So always, tetralogy flow patients, look frame by frame. Otherwise, you may miss severe pulmonary regurgitation. 3D imaging is really helpful to understanding, especially to understand the right ventricular outflow tract anatomy, and to quantify PR, to plan surgery. And the spectral Doppler is very helpful. You can see the regurgitant envelope turns into a more triangular shape instead of a trapezoid, and sometimes it reaches the baseline early too. So all part of a complete examination. All patients with tetralogy flow that can get a cardiac MRI should get one, because it's the gold standard to assess the right ventricular size. So we usually alternate echocardiograms with cardiac MRIs depending on what's going on. And you can see here very quickly, this is in a 3-chamber or LVOT view. You can visualize here if you follow the septum all the way up, you see that you have contraction up to here, and then it ends. This is the patch you can still see the overriding aorta, and you can tell that the RV looks abnormal. And usually when you see this, you can suspect that it's enlarged and that you may have a patch there. And this is a patient with a significantly dilated RVOT and severe TR. You can tell where the patch is if you follow here the myocardium up. You see that here the contraction stops, so all this is patch material, and then we confirm that with LGE. This is how we assess pulmonary regurgitation, or one of the ways we assess pulmonary regurgitation by MRI. We define a region of interest, and then we measure the flow through the cardiac cycle, and this is the pattern in severe PR. You see to and fro flow. And if you like color here, you can see also to and fro. Very clear. This is wide open pulmonary regurgitation that usually leads to right ventricular dilation. And there are some criteria. Patients with severe PR who are symptomatic and likely need a new pulmonary valve, but those that are asymptomatic, they present, the decision is a little more complex than that, and that's where MRI plays a major role in quantifying the right ventricular volumes. We always look at the VSD patch by echo and by MRI to look for residual VSDs, and you can see one here. We don't frequently find them, but this is a patient with reparative flow and a residual VSD. Another view of the defect. And it's very important both by echo and MRI to look at the branch pulmonary arteries, because these patients can have pulmonary artery branch stenosis. So we do special sequences and special echocardiographic images to assess for this and look for gradients and velocity, and especially in patients with elevated RV systolic pressure. So in summary, wow, I did it this faster than I thought. So there are more adults with congenital heart disease than children. So we adult cardiologists need to step up to the plate and learn, and especially those of you that will be imaging these patients. Many surgical decisions will be determined by the quality of your imaging. And this is, ACHD is a growing population. This is a sleeping giant. We'll have more and more patients, and especially also those of you pursuing a career in advanced heart failure and transplantation. More and more of these patients will be in your clinic for evaluation for heart transplant and multi-organ transplant. And we need to be compulsive in the surveillance for frequent issues, complications, and associated defects for each condition. And echocardiography and cross-sectional imaging are critical for surgical planning. The more we interact with our surgeons and meet to review and plan and measure and warn them about potential issues in the operation, the more successful we're going to be as a program. With that, I'm going to end here, and I'll open for questions if any of you have questions. All right. Yes, our fellows know everything. Okay, well, all right. I think then we'll conclude. Thank you.